Okay, next up, we have Damani Piggott. He is an assistant dean and of the graduate studies of the bioeducation and graduate student diversity at Johns Hopkins University. With him will be Dr. Carolyn Belcher. She is my co-chair of this subcommittee for the Health and Human Services, and she is partially the event coordinator, but she serves as the vice president and chief diversity officer at Kennedy Krieger Institute.
Well, thank you, Dr. Gladys Daniels. I appreciate it. I'm Dr. Carolyn Belcher, and I'm going to be starting you off with my colleague, Dr. Piggott. So I'm glad you all are here today. And what we're trying to do in this talk or this series of talks is actually have a discussion, as you see. And we're trying to, through these next series of speakers, answer some of the questions that you sent to us. So we really appreciate that. So I hopefully you all can share my screen, I guess. Yes?
Okay.
Great. So I wanted to start out with some definitions. I think I really wanted to thank Bishop Thomas for speaking the truth and getting us started on this information, and we want to continue that. I think he alluded to this, that race is a social political construct. It's based on physical features. It's not biological. It's a social political construct in the United States. And this term minority, I tend not to use it because I don't believe any of us are minor. So I might talk about Black folk, African-American folk, Hispanic, Latinx, Asian, but I try not to use the term minority. I'm trying to move away from that. But what we also were talking about, and what the bishop mentioned, are health disparities. And these are what Senator Nathan Pulliam, what she was trying to prevent. And those are preventable differences in disease, in the burden of disease, injury, violence, opportunities to achieve optimal health that are experienced. And that is what the task force is about, and particularly the Health and Human Services subcommittee of that. And these are often experienced by people who are marginalized by the larger population. So that could be based on race, ethnicity, gender, sexual orientation, religion. These things can marginalize. So just as an example of that, this is a picture of Black Americans and the percent of coronavirus or COVID-19. You'll hear us talking about both related deaths in the population. So I'm a DC girl. So from Washington, D.C. right now, it looks a little different than it did when I grew up there, but it's 44% Black population, yet 80% of the deaths, 80% of the deaths were in the Black community, okay? And in the area where I grew up, that's one of the hot spots in Washington, D.C., right down the road a piece. So if you look, just say Kansas, 6%. Black population, 32, 4 times the percentage that you would anticipate based on this 6%, over 4 times actually. And then if we're looking at Maryland, which is about 30% Black, then 43% of the deaths. So this virus doesn't discriminate, but there are factors within our society. The bishop talked about food deserts, a lack of access of healthcare, education, employment, insurance, all of these factors, these social determinants that Dr. Gibbons introduced to us that are making a difference in terms of our life and how we interact with this particular virus. And this is another way to look at it. So this is looking at Black, Indigenous, people of color. So we are looking at the number of cases of coronavirus, the hospitalizations and the deaths. In the American, Indian, Alaska Native community, it's really fierce. It's about twice as many as you would predict cases, hospitalizations almost 4 times as high, deaths 2.5 times as high. When we look at the Black population, about 10% higher in the cases, 3 times as high in hospitalizations, twice in death rate. Same Latinx population, about 30% higher, 3 times the hospitalizations and about 2.5 times the deaths. That's overall in the nation. Now let's come to Baltimore. This is Baltimore City here. And there are certain conditions that we know if you have these conditions, you have a higher odds of having severe coronavirus disease. Those are kidney disease, chronic kidney disease, chronic pulmonary disease, COPD, chronic obstructive pulmonary disease or lung disease, heart disease, diabetes, and obesity. And so if we look in the Baltimore community, about 44% of the population have at least one of those disorders. And we know that Baltimore is almost 63% Black. So this is largely reflected on the majority population. So we have to be considered about that. And this is what's resulting in Baltimore City of Black folk having 55% higher odds of death. So we have to be careful with ourselves and those we love. So this is, again, just looking at it a little bit more in the Latinx community in Baltimore City. Baltimore City Health Department has an excellent website. If you want up-to-date information, they're updating it constantly, so you can get information about your community. The 9% positivity rate in the Latinx community. In the Black community, when we're talking about the deaths, it's 1.4 per 1,000. And that is about, it's almost, 50% higher than you would anticipate. The white population, 0.9 per 1,000. Latinx population, 0.6. It's even less in the Latinx population, largely because they are younger when they are more essential in their workforce, are younger. And so their death rate is not as high. I'm going to turn it over to Dr. Piggott at this time.
Thank you, Dr. Belcher. So just starting, so before COVID-19, safe and effective vaccines have been used as an important tool to prevent us from getting infections. In fact, for several hundred years, vaccines have been used as a vital tool in the fight against infections. And today, vaccines continue to be used to keep us healthy from really our youngest years. They actually save millions of lives each year as well. And knowing that the role that vaccines have played as a key tool in the fight against infections in the past, there actually had been, over the last period since this pandemic began, a lot of resources poured into trying to develop safe and effective vaccines against COVID-19. On this slide is a small overview of several types of vaccines that have been studied for use against COVID-19. These include vaccine types called mRNA vaccines, such as the ones made by Moderna and Pfizer-BioNTech, viral vector vaccines, such as the ones made by Johnson & Johnson and the vaccine that's being produced by AstraZeneca, and protein vaccines as well. These are just different types of vaccines. And these studies have actually included tens of thousands of people. These vaccines also have been developed using information from science that goes back from scientific studies done over many, many years. 3 of these vaccines have been approved for use here in the US so far. The Moderna vaccine and the Pfizer-BioNTech vaccine approved in December, and the Johnson & Johnson vaccine approved in February. So on the next slide, just like to share just a brief overview of how these vaccines actually work. So first here is information on mRNA vaccines. These types of vaccines, the mRNA vaccines, actually contain a code that teaches our cells to make a piece of the protein found on the surface of the COVID-19 virus. When our cells make this piece of protein, it allows our body to make antibodies and to really build up and activate other key body defenses that protect us against infection, against the real COVID-19 virus when that virus tries to invade. The vaccine itself does not contain real or living virus, so the vaccine itself can't cause COVID-19 infection,